All right, so we're doing cardiac. Cardiac we did last week actually. So cardiac was coronary artery disease and valve issues and carditis and CHF as a result of all those things. And now we're going to be moving on to other vascular issues. And all usually this stemmed from ASCVD, right? So ASCVD was the underlying problem here. Okay, and that led to CAD, which we already talked about, so check, right? And then we talked about a bunch of different valve issues, et cetera, on the heart and what can happen then. And then now we're going to expand outside the heart. So this lecture is everything besides the heart, all right? So we already did the heart stuff and now the non-heart stuff. So carotid artery disease can result from ASCVD. So we move that now to Med-Surg 3. You'll talk more about that next time. That's kind of a result of strokes. We'll touch on it a little bit next week after your exam, but I know you don't want to know anything about what's the content after the exam. And then aortic disease, we mentioned as a complication of hypertension. We'll mention it again today. But as far as like how it's fixed and all the other things, we'll talk about that more in Med-Surg 3 in your last semester, okay? But today we're going to focus on hypertension. What happens, ASCVD can be an important reason for hypertension, and there's other reasons why you might get hypertension as well. And then CKD, we'll talk about for our last exam, so that's not included in this exam. We'll talk about chronic kidney disease, but ASCVD and hypertension are important reasons that you develop CKD, as is diabetes. And diabetes is an important reason to get hypertension. So just put that over here, right? And of course, you're going to point that out. It's all going to be, everything's going to point to each other eventually. All right, so today we're talking about hypertension, and then we're going to also talk about PAD. Okay, so those are the two big ones we're going to be focusing on today. So PAD is peripheral arterial disease. And yes, carotid artery disease can be considered that, and so can AAAs. But we're focused on where that attacks most, and that's usually the lower extremities. But hypertension is high everywhere. It's high blood pressure all throughout the body. All right, so overview of hypertension. So 100 million people have hypertension. How many people are in the US? About 300 million. So 1/3 of the US population has hypertension. All right, and what is hypertension? It's a blood pressure greater than 130/80. It is silent until it's not, until it actually causes complications, kind of like ASCVD, right? So people don't usually pay mind to it. They don't take their medications. They don't think it's doing anything until they develop a huge old stroke, right? So in red down there in the bottom left, we got the complications of hypertension. Right? So 100 million have hypertension, and a lot of people have pre-hypertension. They're trying to get rid of pre-hypertension, but the pre-hypertension is just before 130/80, right? So 120 to 130/80 would be pre-hypertension. All right, so here's normal is less than 120/80. If you're 120 to 140, somewhere in there, you now have you're either pre-hypertension or now you developed hypertension, right? And then we start going to get into complications here in the red. That's where we start having really, really bad hypertension that can lead to complications, and that needs to be managed. People come into the hospital for a hypertensive crisis. That's when it's greater than 160/110, sometimes 120, but a really, really high blood pressure. They need to get that fixed. Sometimes they come in and the blood pressure is just high. And other times they come in and they have signs of end organ damage or signs of damage due to hypertension. So we'll talk about those things. Okay, so 40%, 1 in 3 Americans have it, and only 50% actually have it controlled. So those that do have it are not controlling their hypertension. Just like diabetics, when they control their diabetes, their A1C is under control. But here, hypertensives are not likely to have their blood pressure controlled. And what does control mean? Not hypertensive. So that is less than 130/80, all right? Death rates from complications are climbing, more than 1,000 per day. People having strokes, people having heart failure, heart attacks, kidney disease, damage from all these things leading to an early death, okay? Hypertension is found especially with diabetics. Diabetics, you develop that hyaline arteriosclerosis, where the artery hardens, and if it's not able to stretch with all the blood volume coming out of the heart, your blood pressure is going to go up. So I'll explain that in the next slide about what blood pressure is. Okay, 75% with CHF. CHF patients are not getting rid of their volume, and also CHF patients are not pumping blood out of their heart. If they're not pumping blood out of the heart, the baroreceptors get activated, the kidneys get activated, the RAS fires off, the SNS fires off, ADH, vasopressin fires off, and now we have this hypertensive state, and that's not going to help someone's heart failure either. Okay, so non-modifiable versus modifiable risk factors, very similar to ASCVD. So age, 65% of those who age get hypertension. Those who are age greater than 65, they get arteriosclerosis, not athero, but arteriosclerosis meaning just hardening of the arteries. And then, of course, diabetics, they have the premature arteriosclerosis with the rock candy. No one ate this from 3 weeks ago. Anyone want rock candy? Yes or no? All right, don't want to get diabetes. All right, and then gender. So gender, equal risk until the estrogen wears off. So females have a little more protection with estrogen. And then black males have the highest risk of hypertension. All right, there's predisposing factors. The older black male would have a lot of air pollution nearby, will put us at risk for hypertension. Inflammation is kind of what's going on here. So air pollution, poor diet, these are inflammatory things that are making our vessels more prone to getting inflamed and getting damaged. And then when they get damaged, you get atherosclerosis can take hold. Fatty streaks can develop. Atheromas can form. Right? And then, of course, those atheromas form, and now that narrows the lumen. That narrows the size of the vessel. So here's a normal vessel right here. ASCVD starts developing and starts developing more. Right? If you ever play with a hose as a person, right, and you narrow the lumen, it's going to go faster. Right? The pressure is going to get harder, going to get, what's the word I'm looking for? Higher, right? So the pressure is going to get higher when you have a narrowed lumen. Okay, so then that leads to hypertension. So they're going to lead, one's going to lead to the other. And then also hypertension itself, even if you didn't have ASCVD, hypertension itself is like doing donuts across all the vessels. So here's our little hypertension molecule doing donuts in the parking lot, and the parking lot being the peripheral vessels. And then it's going to tear up that parking lot, it's going to tear up those vessels, and now fatty streaks are going to fill in those cracks, and now you have an atheroma. So it's, which one came first, the atheroma or the hypertension? Well, that's all going to be cumulative. Okay, so there's modifiable risk factors. Obviously, why don't we prevent the atheroma from developing in the first place? And where does the atheroma come from? What are atheromas made of? Of fat, LDLs, right? So if you reduce LDLs, that's going to prevent the fats from developing fatty streaks and, of course, atheromas. All right, so we get our LDLs under control, get our fats under control. That's going to prevent, someone has hypertension, you want to prevent the ultimate problem of atheromas developing. All right, so diet is an important thing to manage. So if someone has a atherogenic diet. What's an atherogenic diet? It's an American diet, all right? A typical American diet or a standard American diet is SAD. It's SAD because it's going to lead to hypertension, and it's going to lead to ASCVD, and it's going to lead to all these complications down the road. Okay, high salt diet, that's also, we're good at that too. All right, so high salt in and of itself can make us be at risk for getting hypertension. And that can be related to kind of socioeconomic status as well. And it's an ethical question whether socioeconomic status is modifiable or non-modifiable, but that's a story for another day. All right, cigarettes. Cigarettes are never good. You don't recommend just go down from 2 packs to 1 cigarette a day. You'll be cool. No, you recommend discontinuing cigarettes. Cigarettes themselves are adrenergic, so that's SNS. That's another name for SNS. So it's going to vasoconstrict. If you vasoconstrict, what happens to your blood pressure? It's going to go up, so don't smoke. And then also it's inflammatory. So if it's inflammatory, we just kind of mentioned all these inflammation things are going to tear up the vessels, not just because of the hypertension, but just the inflammation itself is going to eat away at the vessel lining, right? And then it's going to lead to atherosclerosis to then develop, right? So smoking is not good for that reason. Being sedentary is not good because obesity usually results, and obesity has adipokines, which are just another fancy word for saying inflammatory stuff, right? And that inflammatory stuff is going to then, same story, it's going to disrupt the vessel lining, it's going to allow atherosclerosis to develop, you get hypertension, hypertension is going to damage more vessels, atherosclerosis develops more, and then you have more hypertension, the more hypertension leads to more complications, all right? And we'll talk about the complications. And then obesity, BMI greater than 30, and then metabolic syndrome. So it rears its ugly head again. It's ugly apple head, right? So apples are not good. So the apple size, the increased waist size is not good. You have a high BMI. Your lipids are whack. All these things are putting you at risk, and of course diabetes or pre-diabetes puts you at risk for developing adipokines, and that's going to cause us to have more atheromas, more atherosclerosis. All right, then stress. Stress is a trigger for the SNS, and we know the SNS being high all the time is not good. So stress is going to be a bad situation as well that we can avoid. Type A personalities or personality like high power CEO jobs where they're stressed all the time, that's going to be a problem. Okay, and then ETOH. ETOH itself is a vasoconstrictor, so that's going to be a vasoconstriction leads to hypertension. And then there's like Europe says don't drink at all, and then America says no, you can have a beer. Men can have 2 beers actually. Women 1 beer. Sorry. All right. So they're okay. America's okay with that. But it's just like cigarettes. Are you okay with 2 cigarettes and 1 cigarette for females? It's like no, just stop. All right. But that is the current recommendation by the American Heart Association. All right, but all this stuff develops, all these modifiable, non-modifiable factors can coalesce and you develop hypertension. What if you don't take care of it? Or you don't ever knew you had it because you're asymptomatic. You're then going to get complications of hypertension. We talked about atherosclerosis, you're forming donuts in the parking lot, right? And that's going to lay the groundwork. Now, how are you going to fill in all those holes? Those are prime hole-filling opportunities by ASCVD, right? By atherosclerosis, by atheromas and fatty streaks and LDLs and such. Okay, so ASCVD will lead to hypertension. Hypertension leads to ASCVD. They're almost like going back and forth. You can put the arrow both ways, right? And that hypertension then leads to CHF. First, it might lead to HFpEF, or heart failure with preserved ejection fraction, which is hypertrophy of the heart muscle, and then that muscle will give out, and you get dilated cardiomyopathy or dilated HFrEF, heart failure with reduced ejection fraction, and then now you have a situation where your heart can't pump. It's out there like this. I can't do it. And then what does the SNS do? You can do it, and it goes and it vasoconstricts, makes it more difficult for it. It's like, I can't do it. No, you can do it. Let's make it harder. Let's increase the afterload even more. Let's increase your myocardial contractility. And it says, hey, you know what you need? You need to buy these things. These are like cabinet selling guys, right? And they're going to say, hey, we're going to redesign you and make you stronger. And then it's like those guys who go to India to get their legs increased in size. It's like you're going to be worse off afterwards. All right, so you're seeing that. Then, of course, the RAS is also developed. The kidney's like, where's my fluid? Where's my blood pressure? And then they release renin, angiotensin-aldosterone system, all fires off. And then now you got the SNS firing, you got ADH is coming out to play. It's all a huge mess. All right, and then that's CHF is more, because as that gets worse and worse and worse, you get more and more SNS and RAS response. So when we talked about CHF treatment, we're really just trying to shut that off as much as possible. All right, so then ASCVD and CHF and hypertension can lead to an MI. And then an MI is just your straight, direct, don't pass, what's the word? Yeah, don't pass, go straight to jail, go straight to CHF. Right, that's going to lead to CHF. And now we're back to square one. We got more CHF, we got more hypertension, we got more ASCVD, we got more, it's a whole downward spiral. Okay, and then vascular damage itself, the damage from hypertension, and then will then lead to end organ damage is the key word here. So different organs die. So you can think of head to toe when you're learning this. You just think from the top, the eyes start to go, right? So they get hypertensive retinopathy. So the vessels in the eyes start popping. And then those vessels that are popped, the blood supply to the retina is not going to be maintained, and therefore you're going to get blindness. So you get hypertensive retinopathy can happen, and vision loss. And then let's go deeper into the skull. The vessels of the skull feed the outside of the face, the external carotids feed the outside, and the internal carotids go into the skull. And now you have a high pressure system going inside the skull, and it's like a pressure washer. It's going to start poking holes in things. It can poke a hole and cause a hemorrhage, a aneurysm to pop. And the aneurysm is just a weakening of a vessel wall, and that's going to balloon out, and that's going to pop, right? And that's called a hemorrhagic stroke. A stroke is just an interruption of blood supply. So if a hemorrhagic stroke can occur, and then if it didn't cause a hemorrhagic stroke, it can then damage the vessels of the brain, allow ASCVD to take hold, and now you got decreased flow to the brain. And then those atheromas, are those stable structures? No, they are very unstable, and then they can just expose their collagen, right? And that's a crime in some states. But you can expose their collagen, and the platelets go, whoa, and they're going to go and attract to it, and they're going to get activated. Now you get a what? You get a clot, you get a thrombus that forms. And that thrombus might form there, and then it might embolize, it might move on up into the brain. Okay, so you get an ischemic stroke. So we'll talk more about ischemic and hemorrhagic strokes next week. We talk about neuro. But an important reason or cause of them is ASCVD and hypertension. All right, and then dementia, just to finish the story. All right, so dementia can happen with chronic lack of blood flow, and just chronic strokes over time can progress your dementia even faster. All right, so we talked about vision loss going head to toe. We got vision loss. We have strokes, hemorrhagic, and ischemic. Ischemic meaning there's no bleed, but it's a lack of flow to the tissue, and the tissue starts dying. The brain tissue starts dying. And then we talked about the heart. You get CHF, you get an MI, and CHF can lead to an MI because it puts more workload on it, and the MI can lead directly to a CHF as the heart muscle has died if it doesn't get intervened upon fast enough. And then aortic aneurysms, if it wasn't a cerebral aneurysm, it can be an aortic aneurysm. That's just a outpouching of a vessel somewhere else in the body, most commonly in the aorta, right? So it can be the thoracic aorta, it can be the descending aorta, or abdominal aorta. All these things can rupture and pop, and that is probably the worst. I think probably in second place to a hemorrhagic stroke. Hemorrhagic strokes actually make it to the hospital. Like 60% of aneurysms that pop don't make it to the hospital. So it's an incredible, and then once they do, like 80% of them die. So it's an incredibly worse outcome of a hypertensive complication. And then chronic kidney disease. So CKD can develop, and that we'll talk about CKD in 2 weeks from now, I think, or 3 weeks or so. But CKD will develop as you're damaging the glomerulus, you're damaging the kidneys, vessels that are feeding all the little nephrons, and those vessels will hypertrophy over time because they're getting scarred, right, from all the donuts happening. They can start getting scarred, and those vessels are very, very small. Same are the vessels of the brain. That's why you get ischemic strokes as well. But all these vessels start getting scarred, and then the glomerulus start dying, they start shutting down, and then you get chronic kidney disease. And why is that bad? You're going to have inability to get rid of fluid, and that fluid is going to lead to CHF, and then CHF, it's a whole downward spiral. Okay, and then CKD also, you get rid of inflammatory mediators, and if you can't get rid of them, they're going to stick around, and now you have ASCVD, and ASCVD you have hypertension, and now you have CHF on two fronts, hypertension and the fluid overload. All right, and then erectile dysfunction. So that's for men, obviously, but that is a problem. That's usually the first problem people will complain of. Let's check your blood pressure. I know you complain of erectile dysfunction. Let's check your blood pressure. Ooh, it's 180 over 110. That's not good. You're going to have to go to the hospital. But otherwise, that could be the reason why you have the erectile dysfunction. It's usually as a warning flag, literally. All right, and then ASCVD. So that will lead to peripheral arterial disease, and we'll talk about PAD today as well. It damages the vessels in the periphery, the upper extremities, lower extremities, usually the lower extremities the most, and that can lead them to be dysfunctional, and that can be very uncomfortable, and that can lead to loss of limb, loss of their leg, loss of their foot. Okay, so we talked about metabolic syndrome before. Metabolic syndrome is where you have these are all predisposing risk factors to developing ASCVD, diabetes, hypertension, and the like. So this guy up here is usually non-modifiable. This guy down here is modifiable, right? The salt intake is something they can fix. The fast food is something they can fix. The sedentary lifestyle is something they can fix. These are all things that we want to try to encourage to avoid, or the things we want to make sure they're not doing, right? Make sure they are exercising, make sure they are taking a good diet, right? All the things we've talked about for ASCVD apply to this as well. The ABCDEs are going to apply to this as well. Okay, so that is hypertension in a nutshell. So pathophys of hypertension, what is happening? So what is blood pressure in of itself? Blood pressure is the pressure of blood. Okay, next slide. All right, so it's the pressure of blood against the arterial walls, and you measure those arterial walls with a BP cuff, right? You measure that cuff, and as that cuff inflates, right, you're going to measure, see that blood fills that artery, right? It fills the aorta, it fills a vessel, it fills an arterial. You're going to be able to assess that, right? So the blood fills the blood during systole as the heart pumps blood out. That's your systolic blood pressure. It's the pressure of blood during systole against the arterial walls. So as that blood hits those arterial walls, you can feel that, right? You can measure it. You can use a sphygmomanometer, which is a fun word to say, right? And that can measure the blood pressure during systole and the blood pressure during diastole, right? We mentioned last week, diastole is a function of arteriolar tone. So these vessels right here, or this blood here, is going to go into peripheral blood vessels, right? What if those blood vessels are super vasoconstricted because the SNS is firing off, ADH is present, angiotensin 2 is present, right? That's going to make the diastolic blood pressure go where? Up or down? Then go up, right? So vasoconstriction, or what's another word for that? Preload or afterload? Or afterload. If afterload goes up, that's a reflection of your diastolic blood pressure, because now the heart has to pump blood on the next cardiac cycle against the diastolic blood pressure. It has to overcome that, right? And afterload is the pressure against that the left ventricle has to overcome, right? So this is your afterload up here. Okay, afterload. And then, of course, what if your vessel walls are super hardened? What's going to happen to your systolic blood pressure? They're hardened because of diabetes or age. That's going to make the systolic blood pressure higher because it's unable to comply, right? The pressure during systole, if you imagine like a vessel, like a water bottle, right? You pour, or like a one of the things that just fell at the beginning of class and was a hazard, right? If that what's it called? What are those bottles called? Stanley, but I'm picking up the old one, the old version, the old phase from 3 months ago. But anyways, those bottles fall off, right? If you put water into that, it's not able to stretch, it's not able to comply, right? But you put that same amount of, let's say you put 100 cc's in, and 100 cc's is really difficult to fix, right? The pressure inside that vessel will be high. But what if it's like a regular plastic bottle or even a balloon, right? You can even add more cc's in there, so the pressure won't be as high. So the hardening of the arteries is going to increase your systolic blood pressure, right? This vessel, the aorta stretches, and it's designed to stretch because then it's going to squeeze all the blood during diastole, right? So there's systole, and there's systole and diastole. All right, so ability of artery to stretch, that's your systolic blood pressure. That can be due to cardiac output changes. The heart rate might be too fast. It might not get enough volume returned from the venous system, right? All this blood has to return to the heart. So what's that called? That's called preload, right? So preload returns to the heart, and the heart needs to pump that blood out, right? And that heart muscle might not be that great. It might have CHF or HFrEF, right? It might have heart failure with reduced ejection fraction, and it can't pump the blood out that well. So that could be that can reduce our cardiac output, right? And if you don't do that, then your heart vessels are going to start squeezing down, right? So they squeeze down, and hopefully that will raise your blood pressure, because it feels that it's usually designed if you're hemorrhaging out or you have a infection or something like that and you're vasodilating, let's vasoconstrict as much as possible to restore our perfusion, right? But when your heart fails, it's a downward spiral from there. Okay, so aldosterone will fire off, the SNS will fire off to try to raise your blood pressure. And then, of course, sodium intake more sodium intake, water will follow, and that will add more preload. So in hypertensive patients, we don't want that. We want to reduce their salt intake to about 1 gram a day. All right, so then ADH also has a role, antidiuretic hormone. It's antidiuretic, so it's not going to diurese water, right? And how does it do that? It takes urea, which is a waste product, and it takes it and puts it back in the bloodstream. And then water follows urea as well. So that will restore blood volume when you're dehydrated, but when you're, when you have CHF, we don't want that. So that's something that will be triggered when we have an SNS response or a RAS response. So ability of the artery to stretch is usually a function of systole. And then about arteriolar tone, the tone of the vessels themselves out here, right? That is a function of diastole. The diastolic blood pressure will go up when you're vasoconstricted. And we're just going to copy and paste SNS, RAS, and ADH, also known as vasopressin, also known as desmopressin, also known as DD, arginine vasopressin, also known as AVP, arginine vasopressin, also known as argipressin. It is in the witness protection program. It has 12 different names. This is why you can't just have one name and call it a day. I don't know. But it's a medication that will vasoconstrict. It's vasopresses, right? Just like our angiotenses, right? Angiotensin 2 and vasopressin are going to vasoconstrict. So will your SNS. Specifically where? Where does the SNS vasoconstrict? Which receptors? The alpha-1 receptors. Alpha-1 receptors are where it vasoconstricts, right? Vasoconstricts at the GI, skin, and renal. We don't need those when we're running away from a bear. When we're dehydrated, we're going to reroute blood away from those areas to restore our blood pressure. All right. So the alpha-1 receptors vasoconstrict, and then we're going to vasodilate to our coronaries, to our lungs, to our brain, to our muscles. But what wins is the alpha-1 because we have a lot more GI, skin, and renal. Right. What's the biggest organ on the body? The skin. What about in the body? The GI tract, right? So those things all vasoconstrict, that's going to raise the blood pressure. The reason I bring this up is because we have medications that are alpha-1 antagonists. We have medications that are alpha-2 agonists. So we'll talk about those guys. Okay, so beta-2 will dilate at the coronaries, muscle arterioles, lungs, etc. Those vessels will dilate during SNS response. And then at the alpha-1 receptors, they're going to vasoconstrict. And that's going to lead those, well, you've got dilation and constriction. Which one wins? Well, you just imagine how many more alpha-1s there are. We are going to vasoconstrict, and therefore, we're going to raise or lower our blood pressure. Which one? We're going to raise our blood pressure. All right, and then there's an off switch for this whole process. When norepinephrine gets released via the little terminals and lands on an alpha-1 receptor, and vasoconstricts ultimately, right? Vasoconstricts. We can turn that off. We can say stop, or it's a way to. It's a self-check mechanism. It says it detects whether there's enough norepi circulating around. That norepi then binds to a little alpha-2 receptor as well, and it's an off switch. So when that alpha-2 receptor is triggered, it's to say, hey, there's plenty of norepi out there. There's no reason to release any more. And we know, and pharmaceutical companies know how to exploit that. They're going to just bind to the alpha-2 receptor and tell it and fool the body into thinking there's plenty of norepi out there. And that will then lead to a drop in blood pressure. All right, so an SNS response goes to alpha-1, alpha-2, beta-1, and beta-2. Okay, you can think of alpha constrict and beta dilate when you talk about vessels. All right, and then beta-1, where beta-1 in all the story? That was all about the heart, or muscle, and EKG stuff, because beta-1, yes, are still involved, but that's going to cause a rise in our heart rate, a rise in our contractility, and also ventricular remodeling, which we want to block, right, when we talk about CHF. So the different neurohormonal processes that are happening. So things that cause hypertension, we talked about vascular anatomy. We got atherosclerosis or arteriosclerosis, either the development of plaques along the vessel, making the resistance higher out in the periphery, right? All those vessels are vasoconstricted, and if all those vessels themselves had atheromas, that's going to definitely raise our blood pressure, right? And then arteriosclerosis, we defined happens with when? With age, right? Inability to accommodate or stretch or comply. And if it can't comply with that volume, it's going to put more pressure up against those walls, right? So in red here, we have things that will increase our systemic vascular resistance, the resistance in the periphery, right? And we have good things that circulate through our body, which vasodilate. Those are things we want. So when we talk about medications, usually the medications are designed to lower SVR. Lower, another word for SVR is Afterload. Okay, and then we got preload there in purple. All right, so what affects preload? These guys here, right? So those are things that can affect preload. So kind of color-coded them for you. All right, so what happens with hypertension? It can happen due to the anatomy of the vessels themselves. They can harden, or they get lined with fatty streaks and atheromas. Or they can be vascular factors. Nitric oxide is a vasodilator. It's good, right? It's what's potentiated with ED drugs, and it vasodilates and causes an erection. It also vasodilates the coronary arteries. It dilates the peripheral arteries. Nitric oxide is good. We want to have nitrates as a way to lower our blood pressure, right? So we talked about CHF last week. Some of our drugs were nitrates. Which ones were those? Isosorbide dinitrate, and also what else? Nitroglycerin, and then we have one that kind of potentiates nitrates and nitric oxide, and that was hydralazine. All right, so those are medications to help reduce afterload, right? Because it's going to vasodilate everything, and also it's going to reduce preload because it's going to reduce the amount of blood that returns back to the heart because all the blood is now in the periphery. So we'll recap on nitrates as well because those are also used for hypertension. All right, and then we have potassium channels. So K channels are cold water, right? And cold water is going to hyperpolarize our membrane and make our membrane stop working. If smooth muscles stop working, where are smooth muscles found? And muscles, where? In the vessels, right? The vessels muscles, all right? So the muscles of the vessels are where those are what cause you to vasoconstrict. So if we inhibit them, right, we cause them to vasodilate, we stop the muscle action, right? That's going to lower our blood pressure, and that's good. So we have one medication that we give for like really, really bad hypertension. We give them what's called minoxidil. What is minoxidil for? There's a fancy word for Rogaine if you grew up in the 90s, right? So it was designed for it was designed for hypertension in the late 80s, and then these guys came back, hey, my bald spots is better now, and some smart pharmacists like, whoa, let me say no more, let me sell this now, right? So now we have a treatment for hair loss, but also it's for hypertension. And then prostacyclins, these get inhibited with NSAIDs. NSAIDs are non-steroidal anti-inflammatory drugs. Those are taken by a lot of people, right? Ibuprofen, Tylenol is kind of a quasi, it's a wannabe NSAID. And there's some other different NSAIDs out there. They get stronger and stronger, and we'll talk a lot about them next semester. But those guys are going to inhibit prostacyclins. The prostacyclins are good. Those guys vasodilate. So if we inhibit those, that's going to lead to some hypertension as well. Endothelin-1, smoking potentiates endothelin-1, and that's going to cause vasoconstriction. So that's the mechanism behind it. And then vascular damage, as we have those shearing forces from the hypertension, it causes free radicals to develop. Free radicals inhibit things, they break things open, they stop nitric oxide from forming, so that's not good. So free radicals are going to inhibit the whole process of vasodilation. So we get vasoconstriction, and therefore we get hypertension. And then we got calcium channels themselves. So calcium channels are when they get stimulated, like a doorbell. When you press a little doorbell, the calcium gets released and it vasoconstricts, right? So we have, and those little doorbells are called dihydropyridine, or DHP, right? So we give DHP calcium channel blockers. They're going to stop the doorbell, no contraction, right? And then we have tissue factors. In our tissue itself, we have adenosine, which gets released with hypoxia. We have acids. Acids, when you have all kinds of acids building up in the office and in the blood, that's going to cause widespread vasodilation, because now when the pH is abnormal, things don't work, right? So your proteins don't work, proteins being actin, myosin, and smooth muscle contraction. So that can happen with increased acid buildup. Right, things that will kill you, they could present with low blood pressure because of that. And then histamines and bradykinins. Those things are not great, because in the respiratory tract, they're going to cause bronchoconstriction, but in the periphery, they're going to cause vasodilation. And it leads to very, very low blood pressures, and it can be very life-altering. All right, and then neurohormonal things. So we talked about this last week as well. AMP, BMP, are those good or bad? Atrial and ventricular with a B. Natriuretic peptides, they natriurease, and natriurease means to what? To urease Na, right? And what is Na? Sodium. So you're going to pee out sodium. That's great. That's going to do what to preload or afterload? That's going to reduce preload, right? It's going to make your kidneys pee out sodium. Water follows. You get a reduction in preload. And then also they happen to inhibit the RAS system, which is an extra bonus, right? If you inhibit the RAS system, that's going to do what to afterload? That's going to decrease afterload, because the RAS system increases afterload. If we stop it with AMP, BMP, that's going to decrease afterload. All right, so again, angiotensin 2 is a function of our RAS system, which is going to do what? What's red? Red is afterload. And the SNS, that's a big factor here. We want to stop the SNS with our medications, but when the SNS does its thing, all right, it's going to do its thing. It's going to increase heart rate, contractility, and it's going to vasoconstrict. It vasoconstricts the arteries and the veins, and it's going to cause a dramatic increase in blood pressure, and that's what we want to avoid. What are triggers for the SNS? I think every lecture we talk about it, but it's what is it? Low blood pressure, but that's not a problem here, right? Low pH, low O2, right? Low sugars, and just movement, right? So, well, then I guess I gotta teach them not to exercise then, right? Because if movement causes the SNS to, trigger off and raise the heart rate and raise the blood pressure and trigger the RAS to fire off, that's not good. But actually, exercise has a lot more benefits. So the benefits outweigh the risks in that point. Okay, and also fever, stress, all the inflammatory things. Where do inflammatory things come from? Is from atheromas, obesity, sedentary. So those things are going to trigger the SNS more, and that's going to then lead to angiotensin 2 to fire off, and then we get vasopressin. It thinks it's helping out. It's going to go in there. ADH is going to fire off in response to angiotensin 2, in response to the SNS, right? And all those things are going to raise the blood pressure even more. So our goal here is to stop these things, right? Let's stop ACE. If we stop ACE, there's no what? There's no conversion of angiotensin, right? So ACE stands for angiotensin 1 converting enzyme, right? So we're going to stop the production of angiotensin 2. A2 is responsible for SNS firing off, ventricular remodeling, vascular remodeling. There's all kinds of things that it's bad for, right? So it's going to stop the vasoconstriction. It's also going to stop its friend. RAS has 2 A's in it, right? What's the other A for? Aldosterone. All right, so aldosterone is going to also be stopped. So you stop aldosterone as well. Aldosterone reabsorbs sodium and water. That's going to increase what? If aldosterone works, that's going to increase our preload, and we want to not have that. That's going to put extra blood pressure where we don't want it, right? So ACE inhibitors stop it. We also have angiotensin receptor blockers, right? And those stop angiotensin, right? So that's the idea here, right? And we also have some nitrates over here that can help out. We want to reduce free radicals. We want to stop these whole processes from getting worse and worse and worse, right? So here's our mean arterial pressure up top here, right? We got systemic vascular resistance, which is another fancy word for saying afterload. And we can stop that. We can help the vascular anatomy, right? That's atherosclerosis, right? And then vascular factors. Hypertension reduces nitric oxide. That's not good. We have tissue factors locally. We have neurohormonal factors is a big one, stopping the SNS, stopping the RAS. We could stop the ADH, but usually that's not usually our goal. We do have a medication that does that, but it doesn't work that great. Okay, so and all those guys will also affect blood volume, right? All these things are going to contribute to a rise blood pressure. So that leads us into medications.